you can present with an acute coronary syndrome with shortness of breath, flash pulmonary edema like this patient did with aortic stenosis. You can have an acute coronary syndrome with an arrhythmia and sudden death, not even able to have chest pain. And you can have chest pain from non-cardiac causes or from cardiac causes with stable angina or pericarditis and not have an acute coronary syndrome. So two necessarily do not mean that they are tied together. But what we are going to focus today mainly is acute chest pain or a clinical syndrome of cardiac symptoms attributable to myocardial ischemia from epicardial coronary artery disease. So that would be the working diagnosis. We'll use the term acute coronary syndrome, ACS, loosely for that. And the chest pain is, the challenge of the chest pain is there's a large number of patients that present to the emergency room. They present to the chest pain centers. They present to the walk-in clinics. They present to the cardiologist clinic. They present to the primary care clinic, primary care doctors with chest pain. 5 million ED visits every year with chest pain. And 2 million hospitalizations out of those 5 million. 3 million are triaged, treated, discharged, over outpatient follow-up. And a small number, 20%, some studies, 25, 27, 30% of them have a cardiac cause. Rest of them are non-cardiac causes. They impose a lot of burden in time, resources, triaging in the emergency room. Not only that, a small number of those are discharged with, later found to have acute coronary syndrome, either unstable angina, come back with an MI, non-QMI, come back with sudden death, get discharged from one ED, show up the other ED and find to have ST elevation, vice versa. And we have all seen that over the years, similar situations. And those patients carry a certain mortality, a certain risk, and a certain morbidity, and certain liability for the physician, for the institution. So it's always been a problem. We always struggle with acute coronary syndrome, and the straightforward ones are not the ones that are the problem. So when patients have come into the emergency room with chest pain, they're not all equal. There are chest pains which are high-risk chest pains like tension pneumothorax, aortic dissection, acute ST elevation, myocardial infarction, acute coronary syndrome. And there are chest pains which are costochondritis, and chest pain which is esophageal spasm, and chest pain which is from reflux and from anxiety and from pull muscle and things like that, which are very benign. The chest pains which are of cardiac nature and chest pains which are of non-cardiac nature. I remember there was a patient who came in from Livingston many years ago with classical chest tightness like a fist, like an elephant sitting here. Put in the ICU, first set of enzyme negative, EKG negative. Went back 2 hours later to do something else, talked to her. Now pain is in the epigastrium, and half an hour later, right upper quadrant. And now then she's exquisitely tender after that, and she's got positive, it catches over here. So it turns into an acute cholecystitis, dual white cell count, and a very nicely evolved chest pain from fist in the chest to right upper quadrant, tenderness and guarding, and ended up having cholecystitis. So the chest pain can be cardiac, chest pain can be non-cardiac. And the cardiac chest pains, the job for us in the emergency room is different from job from us in the clinic or in the outpatient setting. In the emergency room, in the hospital setting, we're trying to decide, is this chest pain an unstable coronary syndrome which has 10, 12, or 8% mortality, or is this a chronic stable angina in somebody with known coronary artery disease which is going to be treated medically? And then there's non-chest pain cardiac syndromes with a new onset left bundle branch block, new onset congestive heart failure, patients who have ear pain and back pain. Over here, our cath lab, we had a lady that came in with left ear pain, emergency room. And this is 4 or 5 years ago. Dr. O'Neill was, got worried about that patient. After 60 minutes, did an EKG. And it showed ST elevation, inferior wall MI, and we did a cath and put in a stent in that patient. So there are some chest pain syndromes which are not chest pain, but toothache, ear pain, back pain, nausea and vomiting with shortness of breath. But what are the big 6 reasons where patients come with chest pain? When you go look up safaris to go to Africa, they have these safaris that promise you the big 5, like you will see lions and leopards and tigers and elephants and rhinos, I think, are the big 5. So what are the big 6 in ED chest pain concept? Those are the big 6 things that every ED physician, every cardiologist, when I go see a chest pain patient, every hospitalist, when you're consulting a chest pain, rule out MI protocol, We worry about these big 6, and some of them are cardiac, some of them are non-cardiac. So of course, STEMI, acute ST elevation myocardial infarction, we don't want to miss it. We don't want to miss it if the patient has a right bundle branch block and ST elevation is being masked by the right bundle branch block. If the patient has pre-existing chronic left bundle branch block or a chronic pacemaker and develops ST elevation myocardial infarction, it's masked, it's not clear. We don't want to miss those, we don't want to miss that one. Then, if the EKG is normal and patient has aortic dissection, that thing has a very high mortality. Pulmonary embolism, tension pneumothorax, pericarditis with tamponade, esophageal rupture. What is the clue here? There are some things that are seen in clinical settings with a high risk of mortality and morbidity. We should think of them, put things together in the proper clinical perspective. If the patient comes in, is hypertensive, has pain between the shoulder blades, has tearing sensation in the back, has a widened mediastinum on the chest X-ray, has a third heart sound or aortic ejection or systolic ejection or diastolic murmur, has unequal pulses, unequal arm, has vascular bruise, missing radial pulse, missing femoral pulse, this should immediately raise the spectral of aortic dissection. There was a patient many years ago. This is the Woodland Heights emergency room. I'm walking out through the ER, just walking out. And in the trauma room, I see a lady head down and all the lot of people around there, nurse and everything, and I'm nosy, so I stick my head in there, so what's going on? Very little blood pressure, 70 over 60 or something, head down, Trendelenburg, and they're trying to figure out what's going on, acute MI or whatever. And the one thing that struck me is a skinny, tall, 28-year-old lady. She was like 6 foot tall or something, just very skinny and very tall. I walk in there and said, "How tall are you, ma'am?" And then I said, "Get me a stat echo," and massive dissection. So Marfan's, dissected aortic root, wide open AI, pericardial fluid, no matter how you resuscitate, this patient needs to go to the OR. You need to call the surgeon then. So everything, I'll just get whiteboard line, central line, transfuse, cross-match to the OR, get the surgeon there. That's what we did. Dr. Williams was the surgeon at that time. That was actually Dr. Kawali's patient's daughter and has been in the practice. But that's just putting things together. Just think of what could be wrong there. Patients immobilized in a cast, long travel. After Katrina, we saw 3 or 4 people come out, stepped out of a car, dropped over, dropped dead, came to the ED here with pulmonary embolisms. I was on call for that whole weekend. Several treated PEs after long travel. They were 8 hours in the car, 12 hours in the car driving from Houston. Tension pneumothorax, young healthy adults, females, skinny, thin, young females, coughing spells, severe shortness of breath, pleuritic chest pain, bodybuilders, weightlifters at the gym, lifting weights, straining, sudden shortness of breath, chest pain, diminished breath on one side. Don't waste too much time getting his EKGs done and cardiac enzymes done and calling the cardiologist. Get a stat chest X-ray, look for a chest tube, and then those patients may crash quickly on you. Esophageal rupture, not only people with history of esophageal disease or GERD or gastroscopy, but EP studies, AFib ablations. We're seeing AFib ablations. Sometimes we see fistulas, sometimes we see perforations from thermal injury, from burning in the left atrium, which is right in front of the esophagus. So that is one thing also to be cognizant of it. We, knock on wood, we haven't seen any so far here, but these are known complications. So just briefly going over these big 6, the aortic dissection type 1, which is stem to stern from the beginning of the ascending aorta all the way down, major DeBakey type 1 dissection. Treatment is surgery. There is new endograft stents being developed constantly. I suspect next 4 or 5 years we'll see a lot of endovascular stenting for these things. Type 2 dissection also. Type 3 dissection, which does not involve the ascending aorta or the arch, distal to the left subclavian, and it is just in the descending arch, and that can be treated medically conservatively. We can actually stent graft those here if they don't involve major vessels like abdominal vessels and renal arteries.
So what is the A and B also?
That's a different class. So there's the DeBakey classification and there is a Stanford classification. Typically, most places have now gradually just moved on to type 1, 2, and 3, the DeBakey classification. So Stanford, the type 1 and 2 will be A, and then this will be type B, type 3, by DeBakey. This is tension pneumothorax. So you see the collapsed lung margin here, and the lack of the lung markings out into the distal periphery, and the collapsed lung edge down here. So how the heart is displaced, trachea is displaced. So this is obviously a tension pneumothorax that will go into, and we occasionally see that after a pacemaker or a cardiac procedure in the cath lab. And that's why we do the chest x-ray and look for these things. Pericardial effusion, CT scan coincidentally picks up very, very sensitive, often overreads it in terms of severity. It doesn't overread it when it doesn't exist, but they will call it moderate and large, and we'll see it small on the echocardiogram. But this is the echocardiogram, left ventricle, right ventricle, mitral valve, aortic valve, pericardial effusion, posteriorly, anteriorly, and CT scan, pericardial effusion. Both will pick up. Pulmonary embolism, this is the CT scan, CT angiogram, main pulmonary artery, right pulmonary artery, left pulmonary artery, and a saddle embolus. The filling defect, the black stuff is the blood clot. This is blood clot, this is blood clot. The white is the contrast filling the artery up. Different patient, right main pulmonary artery blood clot. So we do a lot of those, and we do too many of those. But you have to think of it and you have to rule it out. Does anybody remember the Wells criteria? I had forgotten it actually. I looked it up when I saw the slide and read it. So Wells criteria is something we did during our residency. I think this is a nice thing to have on your cell phone or your smartphone, and look it up and do it. In patients, essentially, patients who have high risk, medium risk, or low risk. And this is helpful because we get the D-dimer in everybody. And D-dimer is extremely sensitive but poorly specific. So if we do a D-dimer followed by a CT angiogram, the patient's coming into the emergency room, then we are doing far too many CT angiograms and doing a lot of radiation to those patients. So what we need to do is restrict the use of D-dimer in people who have high risk or at least intermediate risk by Wells criteria. And then if those patients have an elevated D-dimer and hypoxemia and tachycardia, then we should proceed with CT angiogram on those patients, or VQ scan if we can wait for the VQ scan until next working day availability. This is an example of esophageal rupture. There's air in the mediastinum on the right heart border or the left heart border. The auscultation, you have a mediastinal crunchy noise and sound, and a gastrogriffin swallow study will show you the perforation and the contrast extravasation. So coming out from here, and this is almost just above the GE junction down here, lower part of the esophagus.
Is this the same as Boyer halves they call it?
Yeah.
Yes, this is what it is. This is what it is, yeah. And a medullary bias is just the tear, which is a tear with maybe microperf, which is contained and resolved conservatively. Yeah. And then, of course, the acute ST elevation myocardial infarction, the typical patient and a typical presentation. But we'll get to that in a minute. But let's step back. So these are the big six that we should think of. They are not part of the acute coronary syndrome, not part of, but these are things that are very, very dangerous that will kill the patient, that we shouldn't miss in the ED. We shouldn't miss, even in the cath lab when we do a chest pain and do a cath and it's a clean coronary. You know, the story is not over, the job is not done. They could have PE, they could have any of those things. But let's step back to the chest pain, and before we go and talk about ST elevation myocardial infarction, let's just talk about chest pain with possible acute coronary syndrome. This is a patient comes in, and it's an entire spectrum, some very mild atypical chest pain to very severe diaphoretic, clammy, shocky patient with severe substernal chest pain. And so it includes the acute coronary syndrome patients with STEMIs, non-STEMIs, just unstable angina, non-cardiac, low-risk causes of chest pain from gastritis, gastroesophagitis, reflux, costochondritis, pericarditis, and the cardiac causes of chest pain, like benign causes like pericarditis. And then the non-chest pain causes will also be included in it, like sudden shortness of breath, ear pain, back pain, and things that are not chest pain, but really they're chest pain equivalents. Go over this thing. There's a long list of differential diagnoses. I'm not going to go. Just put this slide up to show you. There's a ton of, there's like 60 different causes of chest pain, and I'll miss some if I go over to 60 with you. But the multitude of reasons you can have chest pains, and people can choose to present to the emergency room with these chest pains, any one of them. But when we look at the patients that have a reasonable acute coronary syndrome diagnosis, about 5 million admissions, 5 million ED presentation of visits annually. This is 2006 or 7 data. 2007 data from CERC. And 1.5 of them get admitted, about 0.3 million with STEMI, and the rest of them with non-STEMI or unstable angina, about equally divided. And when we look at the classification of acute coronary syndromes, let me just get this all done. So the entire spectrum of acute coronary syndrome encompasses one pathophysiological entity. It really is one whole huge clinical picture with a spectrum from light gray to dark gray to black. Whether you have unstable angina, whether you have non-QA myocardial infarction, or whether you have an ST elevation myocardial infarction, they all pertain to a lack of oxygenated blood supply to the myocardium at jeopardy to a variable degree for a variable duration of time. ST elevation is the most drastic, abrupt discontinuation of supply of oxygenated blood to the myocardium, which is sudden, catastrophic, and absolute. There are no collaterals coming in backfilling. There is no trickle of blood going through the occlusion, and there is no intermittent occlusion which opens and closes intermittently. And so you develop a transmural across the thickness of the myocardium from endocardium to epicardium necrosis, myocardial infarction that starts rapidly, spreads like a wave front from the middle of the infarct zone to the periphery, and results in ST elevation because of discordance of the depolarization change from endo to epicardium, and you develop ST elevation that localizes the infarct. Non-ST elevation myocardial infarction occurs when there is an occlusion and diminished blood supply to the myocardium, but it is intermittent and it is not complete. There could be various reasons. The occlusion may be complete, but they may have happened over 10 years and they may have developed collaterals. The occlusion may be intermittent in time where the clot is forming and dissolving. Maybe there is an occlusion 90% superimposed spasm that comes and goes. Maybe there's a fixed occlusion which is 99%, but the heart rate goes up to 50 or 150, 100 AFib with RVR, and your demand goes up and it can't keep up with it, and your troponin is bumped, and you develop non-ST elevation myocardial infarction. But there is enough narrowing and enough activation of platelets and thrombus formation that there is necrosis of the myocardium. That's the non-STEMI. Usually that necrosis will result in some EKG changes, but not necessarily. EKG may be normal. And then there is just unstable angina where there is lack of oxygenated blood and there is ischemia, but it does not quite lead to myocardial necrosis. It's not severe enough to cause myocardial damage, but it is the same pathophysiology, and given untreated, left untreated, will proceed to non-STEMI or to myocardial infarction. So they have the shared pathophysiology, which is an underlying narrowing, on top of that activation of the platelet and coagulation system, formation of a blood clot and obstruction of blood flow, resulting in clinical events and myocardial necrosis. The treatment is very similar too. Decrease the myocardial demand by using beta blockers, resolve the spasm by using vasodilators, whether it's nitroglycerin or calcium channel blockers, use anticoagulants to prevent the blood clot formation, whether you want to use heparin or whether you want to use angiomax, use antiplatelets, whether it's 2B3 blocking agents like abciximab or integralin or agnostat, or use clopidogrel ADP blocking agents like clopidogrel or prasugrel or Brilinta, and aspirin with all of those. So the treatment spectrum is the same. The urgency to treat and intervene varies from STEMI being absolutely urgent and fast, and non-STEMI in between, unstable angina a little bit slower paced. If you look at the mortality, the three differ in them. Unstable angina, of course, the milder spectrum, has lower mortality, both 30 days, hospital discharge 30 days and 1 year mortality. And non-STEMI is slightly more and STEMI even more. So when I first started in clinical cardiology, the ISIS-2 trial was a trial of streptokinase with aspirin in 1988-89. And no, I'm so sorry, 1989-90. And in that trial, our mortality was high teens, 14 to 15% in treatment group, and we were very proud of that mortality. That was very good. So we'll come back and see what the mortality of those patients is today. So when we see these patients in the emergency room with acute coronary syndrome, which could be unstable angina, which could be non-STEMI, which could be ST elevation, or non-cardiac chest pain, what do? So one of the foremost and the paramount thing is history and physical. So the ACC guidelines recommend that in a patient with acute coronary syndrome, within 10 minutes of presentation to the ED, they should have an EKG done and seen by the ED physician or a qualified medical staff, and patient be briefly evaluated by a physician or a licensed medical provider or advanced practice provider. Is that correct? APP. Okay. Chest pain is one of the biggest help to figure out whether this patient has acute coronary syndrome or not in terms of its duration, its location, its quality, its radiation, its persistence, its association, aggravating and relieving factors, and how it has been going on. So where is this pain? Ask the patient. Patient points with one finger here, probably not cardiac. If the patient has band-like fist, chest, central chest, scapular, base of the neck, jaw, ear, just ear, my patient, is probably cardiac. Quality of the pain, is it dull, pressure, ache, heaviness, tightness, squeezing, somebody sitting on the chest? Those are all cardiac pains. If it's stabbing pain, it's sticking pain, it's ice pick, it's burning, it's probably not cardiac. A lot of angina is relieved by burping, so don't be misled by that. So I've seen patients throughout my life that have classical angina and it's relieved by burping. So well written up in the textbook. So burping relieves it. My patient says, oh, this is not hard because that burping gets better. Not true. Not true. Chest pain made worse by exertion, relieved by rest, gets better with nitroglycerin, goes into the arm, goes up to the neck, right side of the neck, left side of the neck, right side of the jaw, left side of the jaw, all cardiac. Above the maxillary line, non-cardiac. Temple, non-cardiac. Temple, non-cardiac. Occipital, non-cardiac. So where does it go? What makes it worse? How does it get better? How long does it last for? Pain that lasts for seconds, non-cardiac. Pain that lasts for 1 minute, non-cardiac. Pain that lasts 2 minutes, non-cardiac. Pain that lasts 5 to 10 minutes is a typical heart pain. Pain that lasts 20 minutes or 30 minutes, cardiac pain, possible. Pain that lasts 2 hours, EKG is normal, cardiac enzymes are normal. Pain lasts for several hours in duration. We start thinking of alternate diagnoses. Because by that time, either you have damage, EKG change, myocardial necrosis, or you look for another explanation for those symptoms. So the history, the point is history and physical, good knowledge of what is cardiac chest pain and good evaluation of that is critical to this game. EKG doesn't diagnose everything, nor does the normal troponin tell us the story, or an abnormal troponin for that matter. Pretest probability of the patient based on their Framingham risk score and risk factors, even though that doesn't really fully correlate. Most of the misdiagnoses are in young, non-smoking women from the emergency room. They say, this is a 38-year-old female with chest pain. Got to be atypical. So Framingham risk score is low in that patient. But Framingham risk score calculation and assessment in every patient, proper assessment of chest pain, duration, location, radiation, quality, exacerbation, relieving factors, very, very important, followed by ECG. And then comes and biomarkers. Now, CPKMB, troponin, IT, myoglobin, and if you want to add BNP to it, high sensitivity troponins, I'm told is still not available in this country. Angela, do you have any idea about that? Recent one? Last time we looked at, this was 6 months or a year ago, it is not available in this country yet, but should be coming up in the near future. Then imaging, stress testing, echocardiogram, CT scan, CT angiogram, and then very interestingly, predictive risk scores. I'm sorry. Predictive risk scores. Are any of you using any risk score assessments in the emergency room, especially the hospitals that are hit by a lot of chest pain? So we'll talk about it in a minute. Let's look about the biomarkers. Let's talk about a normal troponin or normal CPK-MB and a classical chest pain picture. So we say ECG, if it is normal, then it can't be cardiac chest pain. That is not true because a lot of chest pains will have normal leakage in a lot of circumstances. Same thing about troponins. You have a patient with classical chest pain but negative cardiac biomarker, especially if there's just one set. It is totally related to your index event. Now, a lot of this myocardial ischemia, if it comes in, boom, and it stays there for a period of time, you have an index event, you have a timing, and you can assess when your biomarkers will go up because we all know how they rise and how they fall over a period of hours after the presentation, or after the event, not presentation, but event. So if a patient had 2 hours of severe substernal chest pain this morning, and then it started getting a little bit better, and now at 2 o'clock, at 12:30, patient comes here, 6 hours of chest discomfort, index chest pain 6 hours ago, if their troponin and CKMB is still totally normal now, I'm questioning it. But if it just happened 2 hours ago of chest pain, and their enzymes and biomarkers are normal, that doesn't tell you anything. It's not had time to rise yet. It will not rise for another 2 hours. In case of troponin, it may not even rise for another 6 hours because troponin is later to rise. Myoglobin is the first to rise, CKMB is the second to rise, troponin is the third to rise. Myoglobin is most sensitive, but it is very non-specific. Troponin is the most specific, and it's very sensitive, but it's late to rise. You've got to wait out, 6 hours to be confident about it. So, index event, and then is index event a one event or is it a structuring event? If it's a structuring event, patient having 10 minutes of chest pain goes away, 2 hours later have another 20 minutes of chest pain goes away, then an hour later had another 20 minutes of chest pain goes away, never had an index event, never had a reason to pump the enzymes. They're as unstable, as hot, and they may have a proximal LAD lesion, but they will not have positive enzymes. Their enzymes will not bump. So it really is related to the index event, the timing of the pain, duration of the pain, and so assessment and interpretation of this biomarker goes back to your original history and physical, and under what situation they had it. This is the rise, troponin, CKMB, LDH, and myoglobin, and their benefits and their drawbacks. And coincidentally, how long they're elevated for. Look at troponin 5-10 days, and this patient comes in with a big myocardial infarction at 12 midnight, we do an angioplasty, next morning troponin is 100, they call you, then next afternoon it's 90, they call you, and the next night it is 80 and they call you, and the day after is 50 and they call you, it's going to be elevated. Patient goes home, comes back 3 days later, it's going to be 10, they'll call you. But it's still the same troponin. And they'll go to Livingston, it's going to be 0.9 and they'll call you a week later. It's the same troponin. High sensitivity troponins, so how quickly after the index event can we start picking them up, and at what level of diagnostic cutoff. We should be down here at this level of 0.04 positive cutoff threshold and see earlier rise in time. If we have high sensitivity, we can make a more rapid rule out by doing a 2-hour and a 4-hour high sensitivity troponin, and that will improve our accuracy once we have that available.
Is this what we use in our lab?
No. I think we use this in our lab. The cutoff should be pointed. The cutoff varies from assay to assay. So, but the one we use it starts rising at 4 hours. So when we look at after doing the clinical history, electrocardiogram, cardiac biomarkers, we look at the EKG, look at the clinical story, look at the biomarkers, examine the patient, and then we triage these patients and put them into this flow chart somewhere that the patients who come in with ACS, we're not here yet, not these, possible ACS, we find out this patient has non-cardiac chest pain, gallbladder, epigastric pain, costochondritis, soreness, clear non-cardiac etiology, clear pulmonary embolism, we're comfortable with it. Or patient has mild chronic angina, has known coronary disease, no unstability to it, and we can treat it outpatient. But the patients who has possible ACS or non-STEMI, non-diagnostic EKG, normal biomarkers, we cannot say that this is not cardiac, cannot send them home. So we have to observe them. Best thing is, it's a dedicated chest pain only unit. Not UTI patients, not kidney patients, not stroke patients, not everybody else from flow over from every department in the hospital. Every hospital in East Texas going to that observation unit, a pure cardiac, even if it's 4 beds, even if it's 5 beds, but it's a unit where the staff and the unit is geared towards cardiac rapid rule-out diagnosis. They're clued into the patient's history and physical, their biomarkers, their tests, and their EKGs. And that's my biggest thing, because I was very happy 3-4 years ago when I started about this chest pain unit, and it just always becomes something else that you totally lose control over no matter what you want to do to it. Observe them there. No chest pain, negative follow-up studies. Further evaluation as an outpatient. Recurrent chest pain, follow-up EKG changes, possible positive biomarkers. You can do an echocardiogram somewhere in there, see if there is any changes of wall motion abnormalities. Go down, admit the patient, get a cardiology consult, probably need a cath, or probably need a stress test in the hospital, not as an outpatient.
So total time is how long? Like after like more than 12 hours?
12 hours. 12 to 24 hours. Depends somewhat when the patient shows up. The patient's up 7 o'clock in the morning, you can finish this off by the same evening. If the patient shows up 6 o'clock in the evening, you probably by the time next day you see them make rounds and stuff. It depends on the efficiency of your system. If you have a dedicated physician and dedicated unit, then you can expect that physician around there at 7:30. What time in the morning would your rounding physician be rounding on that patient will determine the length of stay for that day pretty much. And if you're going to round after ICU, PCU, and floor and then go to the assessment center, it's going to be 2 o'clock before you round. And if you wait for me to round, I'll round at 5 o'clock in the evening.
Dr. Khan?
Yes, sir.
Quick question. When we were in residency, there used to be mention of left bundle branch block also on
Yes.
ST elevation.
Yes.
Is it out of the algorithm?
No, it is. So when you say ST elevation, you always say and or new left bundle branch block. So left bundle branch block or and or new left bundle branch block. Not all left bundle branch blocks equate ST elevation. Not even all new left bundle branch block equate ST elevation. So a patient of mine who has coronary disease, has normal sinus rhythm, has no bundle branch block, has normal ECG, develops AFib with RVR, and develops left bundle branch block related to age. She is 80 years old, she's got some conduction disease, she conducts fine at the rate of 70 or 80, but when she goes 155, she develops a rate-related bundle branch block, comes to the emergency room because she's short of breath. Is it STEMI? Does she need TPA? Does she need an emergency cath, angioplasty? That's a difficult choice. You have to put it in perspective. If she's having chest pain, you can do an echocardiogram, which is normal. Biomarkers are negative. She's got a nuanced left bundle branch block, but she doesn't fit the ACS profile. Possible. But having said that, whenever you say ST elevation, here you assume the ST elevation and or new left bundle branch block. So ACS early risk stratification within 10 minutes, 12 lead ECG. This is AHA, ACC guideline, level of recommendation A1, level of evidence B. So just for those people who are not familiar, ACC, AHA guidelines have level of recommendation 1, must do, should do, 2A, generally shown to be beneficial, 2B, should do it, not been shown or proven to be beneficial, but is okay to do it, 3, probably is not beneficial, probably harmful, should not do. And then these digits, the alphabets with these level of recommendation, A, B, and C, you will see them. That's the level of evidence. A, high degree of randomized controlled trials, more than one with strong evidence. B, some randomized trials may not be controlled, or some studies but not randomized, some data. C, very little data, but that is the consensus, that is the opinion, that has what everybody agreed upon doing, all the recommendation of the guidelines. So very strong, 1B and 1A, very, very strong. Within 10 minutes of arrival of ACS patient, ECG done. And we do generally a very good job, month after month, day after day, week after week at this of doing that. This involves the shown to the experienced emergency room physician. That shown part, sometimes we fall. Sometimes we put the ECG on the counter and forget about it. Sometimes they give it to the ER physician, he puts it on the side and starts texting on his phone or something, you know. I mean, we're all distractible and distracted all the time. So. But the shown part fails sometimes. And then the other important thing is the ECGs should be serially repeated. Our protocol says, I don't know what it says, 4 hours, 90 minutes, repeat. But hey, it doesn't say don't do it in 5 minutes. It doesn't say you cannot do it in 10 minutes or 15 minutes. Sometimes 90 minutes is too long to wait in an unstable patient with chest pain. So feel free to do it. You walk in there with a chest pain patient, 30 minutes ago was the EKG done, they call you, do an EKG. I come in 30 minutes after, you do another EKG. It is, the cost of doing it is probably $1. The Medicare cost of doing more ECG, probably we don't get paid. We probably eat up the cost of the hospital. Ken is sitting in the corner, so I have to be careful with the numbers. But the information you get is invaluable. Look, you prevent one misdiagnosis is invaluable. It's like MasterCard, you know, priceless.
Well, I think Dr. Khan is right. It's the evolution of changes. You could have a normal T wave and then you see the next EKG, a T inversion or something. Those changes can itself mean something going on with the patient.
Similarly, the cardiac biomarkers should be done. You can do troponin, which is preferred. Some you can make a reasonable argument, just get rid of the CKs and MBs and myoglobin and just do troponins. You can argue it many different ways. But ACC guidelines, AHA, ACC guidelines, 1B recommendation for doing biomarkers, doing troponin, doing in serially at 6 hours, 4 hours, 6 hours, or 6 hours and 12 hours. You can choose timing. You should do it consistently for your own institution. And then doing, I'll come back to this in a second, doing other markers. I think that's right, it's further down the road. Doing other markers is also okay. CKMB is okay, myoglobin is okay, BNP is okay as per guidelines. Level of evidence is B and C for those, but its level is level 1 recommendation. Then there is use of risk stratification models. STEMI scores, GRACE scores, Pursuit, or ADAX models are useful. And let's talk about that because I find it fascinating. So this is the TIMI risk score. TIMI risk score is a risk score assessment not for the diagnosis of acute coronary syndrome, but once you have decided somebody has an ACS, then to decide, is this a high-risk patient or is this a low-risk patient? And that depends on their age, presence of risk factors of coronary disease, like those are Framingham risk factors, the diabetes, the hypertension, the hyperlipidemia, the male sex, the smoker, the family history of heart disease, the sedentary lifestyle. Those risk factors, prior known coronary history, coronary artery disease history, ECG changes, elevation or depressions, frequent chest pain episodes the preceding time, use of aspirin, and cardiac biomarkers. All the websites have it, all the phones, iPhone, Android phones, they all have these applets, and these scores are available on them. So you don't have, nobody has to remember them, you just have to put those things in there and it will spit you up a score. And it will spit you up a mortality. TIMI score of 1 still has a high mortality, so these are all ACS patients. TIMI score of 1, which is low, 0 to 1, has still 4-point-something% mortality or risk of myocardial infarction. And the highest risk scores are 40%. So that helps you triage the patient in your mind. It goes to telemetry, it goes to PCU, it goes to ICU. Do I need a cath tonight? Do I need a cath tomorrow morning? Do I need a cardiology consult right now or tomorrow? You need to know how hot, how fragile, how serious that patient is we're dealing with. And the TIMI risk score is very good. Similarly, GRACE risk score. GRACE puts less emphasis on the prior clinical presentation and risk factors, more on the clinical presentation, the heart rate, the clip class, the presence of heart failure, the blood pressure, troponins, and those things. And again, it gives you odds ratios, and it calculates it, and it gives you a risk for those patients if you put it in the equation. EDAX score is a score that is very useful, and I find it fascinating, and I find it fascinating that it's not used in the ED physicians a lot of times. None of our ED physicians use it. And Angela, I want you to take it up with your ED physician committee and see if they would like to use this score. This is Emergency Department Assessment of Chest Pain Score. This is to triage and find patients which are low-risk chest pain patients who can be safely discharged from the ED with a low risk of events. If you have EDAX score of less than 16, if your symptoms are resolved, if your 2 ECGs and 2 cardiac biomarkers are negative, you have 99% rule out in ACS with a 99% sensitivity of it. Poor specificity, 40%, so it's not specific to diagnose the ACS, but it is very sensitive to rule out the ACS. And it has been shown that the patients can be discharged in 4 hours and be followed up as an outpatient if this score is less than 16. What it is male sex, gender, age of 18 to 85 has differential scores. So from 18 to 40, I believe is +2, and from 40 to 45 is +4, and from 45 to 55 is +6. So it goes up to 20 age-related score based on the age decile that they are in. And then known risk factors, known coronary artery disease, any known coronary artery disease, or 3 risk factors from Framingham score: diaphoresis, radiation to arm, pleuritic chest pain, and reproducible palpable pain has minus scores. If you put it in there, if your risk score is 10 or 12, you can send them home. These are the guidelines for myoglobin. These are the guidelines for other biomarkers. We can skip over those. And BNP. The important thing is we can choose what biomarkers, and that's somewhat of a financial, somewhat of a clinical, somewhat of a practical decision-making process for us. We can choose we want to do it point of care in the emergency room, which a lot of times is not done or not available to all of us. We can choose to do them in the lab, have a rapid turnaround. But we have to do it by a protocol. We cannot be randomly doing it. Some days we are too busy, we'll not do the point of care, we'll do the lab ones. The other days we are doing it in point of care and not doing it in the lab ones. Some days we're doing it 2 and 6 hours, sometimes doing it 4 and 8 hours. We cannot be doing that. We have to have a protocol. We have to be consistent across. And the reason is to prevent errors. One day I'm on call, next day Dr. Kawali is on call, next day Dr. Hudson is on call, one day Dr. Moper is the hospitalist, the other day you're the hospitalist. We all need to be on the same page. We all, the ED physician, the hospital physician, the primary care physician, the consultants, need to know what those protocols are, when to look for them, where to look for them, we don't miss them. And we are a high reliability, zero error tolerance organization, should be, when it comes to those things. So, step back to ACS, no ST elevation, non-diagnostic ECG, 12-hour observation, no chest pain, negative studies, low ADAX score of less than 16 or something. Discharge the patient, outpatient follow-up.
I had a question.
Yes, sir.
On the ED ACS score that you showed, is there a given time frame on the recurrence of the chest pain? You said resolution of chest pain with the 99% probability you can let them
yes,
go.
so in that 12-hour period of time, you have no chest pain. So patient comes in with chest pain, resolves, it's gone, it's pain-free. And you've done 2 sets of enzyme, you've done 2 sets of ECGs, you watch them for 12 hours or 24 hours overnight, whatever your time frame has to be. But if they have recurrent symptoms or ECG changes or positive biomarkers, then ADAX score goes up.
Okay. Patients with that score less than 16, would you recommend them being admitted under OBS or under OBS service or remain in the ER for some hours before they're...
Okay, that's a logistic decision
Yeah.
for the institution.
Right.
So you can have you can keep them in the ER if the ER has enough staffing, a dedicated physician supervisor, and a section you can put them on the right wing of the ED. As such, if your ED is backed up forever, not having beds available, holding overnight patients, you can't keep them in the ER. You can spread them all over the hospital like we currently do, but this is the least optimal of the situation. Ideally, you would have either a dedicated unit like an OBS unit or chest pain unit, or you would have a floor like K5 or a wing on a floor which you will assign to such patients so that your resources are concentrated, your nursing staff is dedicated, your physicians know where to look for it. All three things put together makes it a matter of repetition, frequency, and consistency prevents errors.